vault, while the lower two-third composed of a cartilaginous part. This is the septum anatomy, as you know. This is the quadrangular plate, cartilaginous part. This is perpendicular plate of the ethmoid, and this is the femur with the minor skeleton of the septum. This picture will show more details about the anatomy. This is the upper third, composed of the lateral nasal bone bilaterally with the frontal process of the maxilla. This is the upper lateral cartilage. This is the lower lateral cartilage, composed of lateral crus, medial crus, and intermediate crus and medial crus. The keystone area is the overlapping of the upper lateral cartilage with the nasal bone. And also we have an internal valve, which is important. You would recognize it. It's bounded by the caudal border of the upper lateral cartilage, laterally, septum medially, and anterior head of the inferior turbinate. The angle should be more than 10 degrees. This is the musculature framework of the nose. We have main groups of the muscles: elevator muscle, depressor muscles, compressor muscle, and dilator muscles. The innervation of the nose by the infratrochlear and the external branch of the anterior ethmoid nerves, which comes from the nasociliary, and also the infraorbital nerve, which is coming from the maxillary division of the trigeminal, which is supplying the lateral and subnasal area. So this is the arterial supply, which is coming from the external carotid and internal carotid, mainly by the external carotid coming from the internal maxillary as infraorbital artery and facial artery, divided as angular and superior labial artery. So now I'll talk about the clinical assessment. For the clinical assessment, we have to consider about the facial anesthetic and nasal function. We have to consider for the nasal function because some of the surgeon maybe will take consideration for the facial aesthetic alone, but we have to take consider for them as the same. And we have many points in the clinical assessment. The first point, the pre-operative interviews. We have to establish a good communication with the patient, with his relative and family. Second point, we have to take a clear history of the patient complaint. We have to identify any structural, congenital, traumatic, cosmetic, or functional issues. We have to identify any past history of nasal surgery, sinonasal disease, diabetes, psychopathology, anticoagulant medication, smoking, or cocaine use. Third point in the clinical assessment is the selection of the patient. It's one of the most important points in the rhinoplasty patients. There is a body dysmorphic disorder, which is preoccupation with minor or imagined defect, and we have to be careful about those patients. As well as we have another poor candidate, pneumonic as a Simon, single immature male overly expectant narcissist, while the good candidates, pneumonic as Sylvia, secure, young, listen, verbal, intelligent, and attractive. We have a general and specific questionnaires for the rhinoplasty patient. The specific questionnaires like cosmetic procedure screening scale, body dysmorphic disorder questionnaire, Yale-Brown obsessive scale modified for body dysmorphic disorder, dysmorphic, and the last one is dysmorphic concern questionnaire. The general questionnaires like Ford appearance scale, fear of negative evaluation scale, and hospital anxiety and depression scale. Also, we have to ask the patient many questions like those which is mentioned here. What's the nature of your appearance concern? What do you dislike about your appearance? Is this a cause of distress or preoccupation for you? When does the feature bother you most? Does this impact on your family daily functioning? Have you had previous treatment to improve your appearance? Do you have other body areas of concern? And also, we have to take care about the red flags for the rhinoplasty patient, like body image concerns that are difficult for others to see, and realistic expectation of treatment outcome, worrying about body image repeatedly throughout the day or for long periods, use of camouflaging and cover-up strategies, constant requests for reassurance, mirror checking or avoidance of mirror, avoidance of social situation, and so on. Also, we have to assess the expectation of the patient through the questions, which is mentioned here. What are your outcome expectation? How do you anticipate your life will be different following the treatment? What if your expectations are not met? Actually, the studies have shown higher levels of dissatisfaction in personal appearance in patients seeking rhinoplasty than other patients or seeking the aesthetic examination. We have to assess the external nasal deformity, quality of skin, facial analysis, and nasal analysis, as Dr. Ali Hasiri mentioned before in the first lecture, and the internal examination. The last one, photographic documents. We have to take photographs for the rhinoplasty patient from different angles, from the front, basal, lateral, and oblique. So before the surgery, we have to be conservative. We have to know when should we stop. Never promise miraculous result after surgery. Beware of psychotic patients. And the last most important, the consent. Now I'll talk about the deformities. We have different areas of the deformities. I'll start by the tip. Could be bulbous, pivot, overprojected, underprojected, and ptosis. The columella either to be deviated, broadened, retracted. The alar cartilage, pinched or flaring. Osteocartilaginous fault, deviated, saddling, humping, or tension nodes. This one, these are the examples of tip deformities. As you see here, this is a bulbous tip, this is a pivot tip, this is over-projected tip, and this is under-rotated post-surgery. Columellar defects, the retraction of the columella. This is a flaring. This is a pinching of the ala, and this is a flaring of the ala. For the osteocartilaginous deformities, as you see here, this is a deviated nose, this is a hump nose, this is a polypeak, and saddle nose. The quality of skin, we have to check it. The thick skin, mask-free refinement and definition. Failure to contract because there is excessive soft tissue scar, does not show small irregularities. While the thin skin, small irregularities will be visible, early healing, and less edema. The types of rhinoplasty, either open or closed. The open approach can be approached by the transcolumnar incision, while the closed approach by endonasal rhinoplasty incisions. I'll talk about the external approach. The indications of external approach: extensive revision surgery, severe nasal trauma, congenital deformities like cleft lip node, marked tip deformities, elaborate reduction and augmentation procedures, correction of extreme overproject. The principle of the external approach: the incision mid-columella incision connected to bilateral marginal incision, dissection in subperiosteal and subpericondylar planes, division of medial intercrural tissue overs, access to caudal septum and premaxillary spine, division of upper lateral cartilage from quadrilateral cartilage offers accessibility to whole of the the septum. The advantages of the external approach are extensive exposure for both septal and rhinoplasty surgery, use of both hands, control of bleeding and hypothermia, precise placement and suturing of struts, patterns, and shield grafts, and the valve will be more preserved. Surgical technique, broken transcolumnar incision, as we mentioned. Columella short, in case of cleft lip, we will use fixed incision. Mid-columella incision situated above medial crural foot plates. Vertical columella incision should be made 1.5 to 2 millimeter inside the vestibule. Dissection carried in the midline just cephalic to dome, subpericondrial plane. Dissection of soft tissue of bony pyramid should start above caudal end of the nasal bone. Nasal septum between medial crura of the lower lateral cartilage or hemitransfixation. How can we use it? And as we mentioned before. Now I'll talk about the reduction rhinoplasty. The indications of reduction rhinoplasty: patients with ideal height and position of the nasion associated with excess dorsal convexity or oversized alar cartilage producing increased tip and lobule volume. Aims: strong nasal dorsum and the lateral profile relate to ideal nasion height, tip defining point projecting just above dorsal line to create supratip break. In males, may be on straight line with dorsal. Techniques, we have nasal tip surgery or the humping. Nasal surgery, the cephalic trim, cephalic trim for volume reduction of lower lateral cartilage, as you see here in the diagram, through the transcartilaginous incision. 5 millimeter of continuous strip of lateral cross of lower lateral cartilage is used. This is how can we do it. For humping, as we know, the humping may be bony, cartilaginous, or both. For the bony, we are using intranasal approach with the rasping. Cartilaginous, if it is small, we are shaving the cartilaginous ridge, the dorsum. If it is both, we are prefer the open approach. So this is how can we do the deviated nose. So as I mentioned before, the nose composed of 3/3. So I'll start by the treatment of upper third, which is the bony pyramid. The medial lateral transfers osteotomies at the level of the medial canthus, allow shifting of the pyramid back to the midline. Minor deformity treated by unilateral osteotomies. Disruption of keystone area can lead to notching of the dorsum, which is called saddling of the nose. This diagram shows the different types of osteotomies. This is a lateral. This is a medial osteotomy. This is intermediate, and this is transverse osteotomy. Medial osteotomy, the nasal bone separated at intranasal suture through the short intercartilaginous incision. Lateral osteotomy, we have types of lateral osteotomy, low to low, low lateral, or low-high lateral osteotomy. Intermediate osteotomy, nasal bone has a very convex, concave, or irregular topography. An intermediate osteotomy may be necessarily between the medial and lateral osteotomies. If doing intermediate, should be before the lateral osteotomy. Transverse osteotomy separates the bony pyramid from the frontal bone and nasal spine of frontal bone. Osteotomy made at level just below the nasal. The treatment of middle third by shaving of the convex part of the septum, also use of bilateral and unilateral spreader graft, as you see here in the diagram. This is a deviated nose, and this is after applying an insertion of spreader graft. The reconstruction, the bony septum, resection of most prominent part, cartilaginous septum, resection of redundant and displaced cartilage, scoring concave surface of the cartilage, and also correction of the subluxated caudal septum. The treatment of lower third, if the nasal spine central, the posterior septal angle should be sutured with figure of 8. Locking technique, which is untrimmed displaced caudal septum, is placed on contralateral side of the thin nasal spine. If the caudal septum is absent with deviated tip, will require an replacement with the graft. Now I'll talk about the nasal tip surgery. As we know, we have a support for the nasal tip, major and minors. The major 3 supports, which is the medial and lateral crura. The second one is the medial crura attached with the caudal septum. Also the attachment of caudal margin of the upper lateral cartilage to the cephalic margin of the alar cartilage. The minor support like dorsal cartilaginous septum, interdomal ligaments, membranous septum, nasal spine, surrounding skin and soft tissue, and alar side wall. This is a tripod theory. The nasal tip has 3 legs, medial and 2 lateral, which is the medial crura in the midline, and the lateral lateral crura from the lateral side. If there is a more rotation, that means the midline or the mid crura will be elongated and the lateral crura will be shortened, and vice versa for the derotation. Surgical approach, we have different types of incisions. As you see here, we have a transcolumnar, marginal incision, transcartilaginous, and intercartilaginous. For the approach, we have delivery or non-delivery of the cartilage, open approach, or retrograde approach. Intercartilaginous incision made at the junction of the caudal border of the upper lateral cartilage and the cephalic border of lower lateral cartilage. Retrograde access to the lateral crura of the lower lateral cartilage. When combined with marginal incision, it allows the surgeon to release and deliver the lower lateral cartilage as bipedical chondrocatenaceous flap. Transcartilaginous incision, size through vestibular skin, similar to intercartilaginous, but 3 to 5 millimeter caudal to the cephalic end of the lower lateral cartilage. This is caudal to the nasal valve, so it will decrease the risk of nasal obstruction. This is the level of the incision of the lateral lower lateral cartilage. Transcolumnar and marginal incision. This is for external approach. Crosses columella just above the flared ends of the medial crura. Vertical columnar incision placed 1 to 2 millimeter inside the vestibule. As you see here, we're doing the transcolumnar with the marginal incision. For tip defining procedure, we have a lot of methods. The removal of cephalic strip of lower lateral cartilage, vertical division with or without strip division of lower lateral cartilage, tip suturing, tip grafting. This is the intradermal method. We have here a bulbous tip and the interdermal suture applied, and we'll end up with tip definition. This is how can we do it. Unprojected nasal tip caused by smaller alar cartilage, middle and upper third disproportion, maxillary and mandibular abnormalities. The methods for underprojected nasal tip, including Goldman tip, only graft, lateral crural steel, and shield graft. Goldman tip and crural strut. The procedure is vertical division of dome 2 millimeter or lateral to the apex cause lengthening of medial crura segment. Allows increased projection. The cartilage strut 3 to 4 millimeter wide, placed and sutured between medial crura. This is also the second method. We can apply the overlay graft over the nasal tip. Lateral crural steel, alar cartilage resected in intermediate crural area. Alar cartilage may be delivered. Lateral crura advanced to medial crura and sutured. Will give tip advancement and rotation. Last one is shield graft, as you see here. So indicated for narrow middle nasal fold and the projected tip, as we said, weak lower lateral cartilage. For the projecting tip, which is caused by overdevelopment of alar cartilage, nasal spine, caudal septum, quadrangular cartilage dorsum, also can be caused by elongated columella, and the last by the iatrogenic overprojection. It's corrected by many methods. The first one is transfixation excision, vertical dome excision, medial and lateral vertical segment excision. Vertical dome excision, the division of alar dome 1 millimeter lateral to highest point of dome, intermediate crura rotated anteriorly, intermediate crura sutured with the medial crura stabilized their height trim. Now I'll talk about the tip rotation techniques. We have either complete strip technique or interrupted strip technique, which is including lateral, medial, or lateral interrupted with suture. The complete strip, as you see here, we are resecting part of the cephalic, part of the lower lateral. So more resection of the, as we said, we have to leave at least 5 millimeter of the caudal part of the lower lateral cartilage. But they said if we take more cephalic part, we will get more rotation. This is the interrupted strip technique. It's interrupted from the caudal end. Augmentation rhinoplasty. I'll talk about the saddle nodes. It can be caused by the trauma, nasal surgery, familial, ethnic, infections, chronic inflammatory conditions, or tumor. The properties of implant material should be non-carcinogenic or non-immunogenic, non-toxic, non-destructive. Physical properties match the local tissues, non-resorbable, easily available. We have types of materials. The first one is autograft, like cartilage, bone, dermis, and fascia. Homografts, like irradiated rib, old acellular dermis. Xenograft, leather, ducts, sternum, bovine cartilage. Precious material, like titanium, gold, and silver, metal alloys. Synthetic component, like silicone and so on. Synthetic biomaterials, silicone, Teflon, Proplast, Cortex, Midbore, Mercilin, titanium, and ceramics. The types of autograft, we can harvest the cartilage, the graft from the septal cartilage, auricular cartilage, costal cartilage, or bone graft. The septal cartilage, we are harvesting the harvested used hemitransfixation, transfixation external approach, harvested posterior to an imaginary line drawn from the anterior nasal spine to osteocartilage junction. Septal cartilage is more rigid and easier to curve and reshaping. For the conchal cartilage, it's 3.5 centimeter in length. The antihelix fold should be kept intact. Can be harvested by anterior or posterior approach. For the anterior approach, incision is given just anterior and deep to the antihelical fold. Skin is elevated from the underlying cartilage by blunt dissection up to the posterior edge of the external auditory. This is how can we harvest the bronchial cartilage. Costal cartilage, the straight rib cartilage harvested from the 6th to 8th rib through 3 to 4 centimeter skin incision. The rectus abdominis muscle is split vertically and retracted. Management, the surgical approach by the open approach, preparation of graft and implant, use a template. We have to use a template to achieve the exact size. We have to avoid abrupt edge, suture fixation in case of layered cartilage. And also we have to prepare the bed of the graft by the rasping to remove the irregularities. And the last one is splinting by percutaneous securing sutures and external nasal splint. This is a nasal saddle nose, pre-operative and post-operative. This is and this is post. The last topic I'll talk about is the complication. This is a systemic review, was published in 2020. They conclude that the certain complications such as dissatisfaction and revision surgery should be included in every consent procedure. And also this systemic review will give or will provide very helpful framework as well as valuable information in pre-operative counseling. This is the list of the complication was mentioned. The systemic review started by acne. By the way, the complication mentioned here in order of average incidence. The most incidence one is the acne, then numbness, hospital revisit, revision, and so on. These are my references. Thank you for your listening.
يعطيك العافية.
Thank you دكتور عبد الواحد. تفضل تفضل.
أول شيء يعطيك العافية أبو الوليد. and شكرا دكتور ضيف الله على حضورك وتشريفك، وكمان أشكر الزملاء على الدعوة. دكتور عبد الواحد, really it was a nice presentation which I like it a lot. And as you mentioned, it will be difficult for us to cover rhinoplasty topic in one lecture. So, but I think you covered well. And just I would like to emphasize about some things, which is about the internal nasal valve, which is really the most resistance nasal airway area. So once we are dealing with the septoplasty or rhinoplasty cases, we should address the internal nasal valve well and be sure it's patent. So this is the number one. And regarding the importance of the pre-op assessment, I found in the pre-op assessment, if you spend a lot of time with the patient, usually the outcome and the patient will be happy about the surgery and about his outcome, because he will be realized and he will understand the things that can be done and something that cannot be done. So when you spend the time with the patient, especially with the photography, and there is some software so you can use it. Once you use this software, it will help you to get the patient what does he need, and also we can get the patient expectation. So the pre-op assessment, I think it's the most important thing, especially in any facial plastic surgery cases. And as you mentioned, the list of the consent for patient who's there is a lot of risk and a lot of side effects of the rhinoplasty procedure. It can be up to death. Yeah, it's rare, but it can be happen. It's more than 36 complications, and it should be involved the skin complication as well, because the most common, as you mentioned, Dr. Abdulwahed. And thank you. Prof Ali, you are raising hand. تفضل.
أولا بسم الله والحمد لله وأصلي على نبي الله. Well done, Abdulwahed. Excellent presentation, very informative, comprehensive. you cover most of the important basic area. Your presentation will be complete if you have a video to show the surgical procedure, especially for our young resident who didn't see the rhinoplasty. It will be perfect. Just what I want to emphasize, important point, especially in the anatomy, every resident, he should know the major and minor support of the nose. This is one of the favorable questions by the examiner. And the resident, he should know the 3 major and 7 minor support of the nose. And if he disturb, especially the major support, he should reconstruct that area. It's very important when you select your patient to make sure psychological assessment and always consider the body dysmorphic disorder